There is quite variable performance of blood tests that are available for clinical care. And this is problematic because we don't want to be misdiagnosing people with Alzheimer's disease. There has been suggestions that we could use low-performing tests in, for example, a primary care environment just to screen people or triage people. And if they have a positive results, then they are sent to a specialist. If they have a negative result, then they are thought not to have any Alzheimer's disease pathology, so that it's been ruled out. However, there are issues with this. So one is that right now our specialty dementia clinics are very busy, and we really don't have the capacity to see a lot of false positive patients. And some of the tests that have been developed have about the same number of false positives as true positives, especially if you run them on a more general population, including some younger individuals. So if people do a lot of screening with these low quality tests, it will just overwhelm the system. So we don't want to encourage that. The other issue is that some individuals who get these tests in primary care may not ever make it to a secondary care provider. And so again, we don't want a lot of individuals thinking that they're false positive because, or thinking that they're positive when they're false positive and not being able to get a follow-up test. So really because of concerns about false positive results, we set a standard for primary care of blood tests having a sensitivity of 90%, and that's so that they will catch people who are positive, but also a specificity of 85%. And that's so that we don't have a high rate of false positive individuals. Now, if you are in, for example, a dementia specialty clinic where there is ready access to confirmatory tests like CSF or PET, then you may be able to get away with a sensitivity of 90%, again, so you don't miss people, but a lower specificity all the way down to 75%, because the expectation is that all of the positive individuals who are false positives will have a second test that will reveal that they were false positive. So for this triaging purpose where you're planning to do a second test, we think for primary care that sensitivity of 90%, specificity of 85% is appropriate in primary care. And then in specialty care, where you have good access to confirmatory tests, we think that 90% sensitivity and 75% specificity may be sufficient. Now, there's a second use of these blood tests, and this is, you could kind of think of it as standalone. What I mean by that is you're not performing a second test. You're not performing a follow-up confirmatory CSF test or amyloid PET scan. And to use the test, a blood test in this way, you really have to be convinced that your blood test is as accurate as the CSF tests. And what we looked at the currently FDA-approved CSF tests for Alzheimer's disease, and they have 90% sensitivity and 90% specificity for amyloid PET. And so we think that that is a reasonable threshold for these blood tests. We did not think it was reasonable to expect the blood test to be more accurate than a CSF test. But we think that if the blood test is as accurate as a CSF test, that it's reasonable to use it by itself without follow-up testing with CSF or amyloid PET. So overall, these guidelines were put together to help patients and clinicians and diagnostic companies to really think about how good do blood tests need to be useful in clinical care and to be appropriate for clinical care.